What I'd like to do is I have a couple of PowerPoints that briefly cover insurance risk and risk shifting and the fundamentals, and then some of Ed Weisbart's recent slides on much more detail of what Medicare Advantage does and what direct contracting entities would do, and then open it up for Q&A. And I want to go through the PowerPoints fairly quickly because I think a lot of you have seen them before, and I don't want to bore everyone, but I just want to get things oriented for the Q&A. Okay.
Yeah.
Okay, so this is the review of the fundamentals of insurance and risk. So an optimal single payer program should have one payer that pays providers of care directly with no financial middlemen, no risk-bearing entities in between the payer and the providers of care. And it should have budgets for institutional providers of care, which are not based on opportunities for profit or loss, but just based on the cost of operations and salaries for their professional staff, and a simplified standardized fee schedule for independent professionals and negotiated price controls for drugs and durable medical equipment. These are what it would take to make a single payer system truly cost effective. So insurance risk is designed for risks that are infrequent, expensive, and unpredictable, like lightning hitting your house and having it burn down. And if a risk has all three of those characteristics, then the main way risk is managed is risk pooling, where everybody chips in a little every month, and when somebody has a disaster, the money is there to cover it. But if the risk is at least partially predictable, then insurance companies introduce underwriting, which is the analysis of risk in order to either charge more for it or avoid covering it. And that is counterproductive to the whole purpose of healthcare. And in healthcare, way too much of the risk is predictable due to pre-existing conditions, demographics, and social determinants. So if you don't avoid risk, if you don't engage in risk avoidance by trying to cherry pick healthy people or screen people out from coverage, you will end up losing out financially and get killed. And that's called the adverse selection death spiral. And if you offer a better plan, the sickest people will sign up first. So you don't want to do that. You want to be a little worse than the competition. And if you employ underwriting, which happens to be restricted under the ACA, but not completely banned, that undermines the whole purpose of health insurance. So the whole idea of applying the insurance business model to healthcare is a huge mistake in the first place. Whoever has the money and is stuck with covering the variability and unpredictability of healthcare costs is the bearer of insurance risk. The clearest example is capitation, where you pay an entity, whether it's a primary care doctor or an insurance company or an ACO, a fixed amount per person per month in exchange for an obligation to cover those people's healthcare needs for a defined period of time. The problem is that if you're held accountable for the cost of care, that depends largely on patient characteristics, not how good a job you do of taking care of them, which means your incentive primarily is to avoid sick people rather than just do a better job. So a risk-bearing entity has defined assignees or members, and it's paid by the enrollee or assigning member, and enables whoever has the risk to profit or lose based on how much they spend on care. And when you get for-profit entities coming in as middlemen, what they try to do is make it sound like what they're going to do is give better care, and that's how they're going to save money. And what they really do is they cherry pick and lemon drop and game documentation to beat risk adjustment. So capitation conveys risk. Global operating budgets do not. If you're on a budget and you have money left over at the end of the year, it gets rolled over in the next year's operations. You don't get to keep it. And if you lose money because something unexpected like a pandemic happens, you ask for a supplemental appropriation to cover the budget, or you make it up in the following year. And there's no retained earnings. There's no profit. Okay, social insurance, which is what single payer is, means risk pool is the entire means of risk management. Everyone is in one big risk pool. There's no breaking up the risk pool into competing subpools. There's no risk avoidance, no underwriting, no cherry picking, no exclusion of high-risk patients, and no gaming of documentation to beat risk adjustment. So the rationale for shifting risk onto intermediaries is that the theory is that we have such expensive healthcare because we deliver too many services, because fee-for-service incentivizes maximizing volume of care. Therefore, the solution is if you push insurance risk onto providers of care, like doctors and hospitals, and they're held accountable for the cost of care, then they keep more money by delivering less care, and then they will not deliver unnecessary care due to fee-for-service. But this requires big data. You've got to be able to track how sick people are, what their risk is, try to figure out how much to charge for your, or negotiate for your capitation rate. And that means the insurance industry has a cemented role for themselves in healthcare as suppliers of that data. The problem is the premise is false. Utilization of care in the US is toward the low end of industrialized countries that cover everyone for half what we do, usually using fee-for-service. And there's no evidence of excessive utilization in primary care paid with fee-for-service, yet that's who we're trying to capitate. And risk shifting creates perverse incentives to skimp on care and avoid sicker or socially disadvantaged patients, aggravating disparities. And the counter incentives to these are pay for outcomes, which increases the incentive to cherry pick, and risk adjustment, which is way too complex to do accurately and just leads to a lot of gaming. So we tried risk shifting with managed care in the 90s, with pay for performance in the 2000s, with value-based payment in the 2010s, and value-based payment was built into the Affordable Care Act. And now we have direct contracting entities in 2021, which is the latest effort to apply the same idea, shift risk onto intermediaries. So if you try to use market forces to control prices, which is the theory in US healthcare, the administrative costs are 5 to 6 times that of public systems. The incentive is to avoid risk. There's a race to the bottom among plans, and misguided and costly efforts to manage healthcare via bureaucracy. And it doesn't improve healthcare, reduce costs, or add value. So the forms of intermediaries are an HMO, which means that you have an integrated system of multi-specialty physician group and hospital or hospitals, and enrollees sign up for the plan. They are members. They either pay a premium or the government pays it for them, and they have to get all their care from that system. And that system then, if they deliver too much care, they lose money, and if they skimp on care or enroll healthy people, then they make money. And of course, Kaiser flagrantly markets to healthy people. They're the classic example of an HMO. And many insurance companies offer open panel HMOs with networks of independent providers that essentially works the same way. And Medicare Advantage and Medicaid managed care are examples of HMOs. An ACO is created under the Affordable Care Act, and it's like an HMO, except the patients don't sign up for it and don't know they're in it, but they get attributed based on where they seek care. So whatever primary care doctor they see the most gets paid the capitation rate, and they don't even know they're in an ACO. And once they're attributed, then the payer can pay with capitation or partial capitation and shift risk onto the doctor. And this requires quality metrics and pay for performance and risk adjustment. And that requires detailed documentation and data reporting and carries high administrative costs. So a direct contracting entity is a new animal that's created to get the rest of regular Medicare captured by capitation and fiscal intermediaries, or basically to privatize the rest of Medicare. And like ACOs, you don't sign up for a DCE. Whoever you see for primary care, if they joined a DCE, then you get aligned with that DCE using the terminology CMS is using. There are 53 pilot DCEs around the country, most sponsored by physician and hospital-led ACOs, some by insurance companies, and some by venture capitalists who are looking to see making profits off of taxpayer-funded healthcare. The insurance companies, there's only 6 of them out of 53, but they cover 57% of all the people that are in DCE. So they're actually the largest section. The GEO version of a DCE would force all traditional Medicare patients into DCEs within a defined geographic area. But this has been put on hold by the Biden administration, and we don't know if it's going to get implemented. But that would completely eliminate traditional Medicare in the specified geographic areas. Okay, that's my brief review. And now I want to switch to Ed Weisbart's slides. Okay, Ed starts with Medicare Advantage because this illustrates all the things that can happen with DCEs. So you have your Medicare health insurance, and you can have traditional Medicare with no intermediaries, which pays providers of care directly, or you can sign up for Medicare Advantage, which is insurance intermediaries that take the money and are responsible for the care. And they claim that they're going to coordinate care and improve access and save money because they'll eliminate unnecessary care, et cetera, et cetera. That's what they claim.
Steve, we don't see the slides yet. I don't anyway.
Oh, you don't? Oh, let me go back.
Yeah.
Now can you?
Yes.
Okay, great. So there's the Medicare Advantage is an alternative to traditional Medicare, which inserts insurance intermediaries between the payer and the providers of care. And Medicare Advantage is a money machine. The primary care doctors submit more codes. The Medicare Advantage plan submits more codes to CMS. CMS pays more to the Medicare Advantage plan because the more codes you submit, the sicker the patient appears to be, and you get paid extra according to their risk adjustment formula. And seniors end up paying higher Part B premiums to cover the extra cost of all this gaming. And the plans offer things like gym memberships and some enhanced benefits to lure people into them. So more members join the plans, and then the plans grow, and then they have higher dividends, stock buybacks, more profit for the owners, and more political contributions. And they keep on submitting more codes, and they gain this as a cycle. And so the result is this is a very lucrative model for Wall Street. So physician coding drives risk scores, and the more codes you have and the sicker they look, the more reimbursement you get. So for somebody who's age 76, who has no extra codes put in, CMS might pay $4,000 per year. But if they're coded for type 2 diabetes, congestive heart failure with diabetes, all those result in upward adjustments to the risk adjustment score. And then they get paid $9,000 per year. And if they use more detailed coding, like morbid obesity, diabetes with retinopathy, major depression, single episode, mild, congestive heart failure, class 3, COPD, ulcer, stage 3, congestive heart failure, diabetes, and COPD, then they get an even higher risk score. Now they get paid $32,000 per person per year, which is a huge difference. So higher coding is a risk score game that's designed to optimize business results. The insurance companies literally send out so-called case managers to either hospitals or doctors' offices or patient homes looking for more diagnoses. They comb through the charts to see if they can find more diagnoses to code. They ask the patient questions, and anything that might suggest another diagnosis, they add it to their codes. Yeah, home care visits, wellness exams, monthly PCP office visits. They mine electronic health records. They use artificial intelligence and machine learning software tools. And they give providers incentives to submit more and better codes. Direct financial incentives. They have strategic pricing to optimize planned financial results. and the result is large profits. And there is a whole new industry built up around trying to help them do this. Home visit companies, analytic startups to drive identification of codes, electronic health record modules to drive capture of codes, artificial intelligence and machine learning, language coding software, primary care Medicare Advantage focused startups, strategic bidding of actuarial support, all claiming to improve outcomes, but this is financial outcomes, not clinical outcomes. They've become masters of coding. The average risk score has risen dramatically since 2007. Mortality rates, drug prescriptions, and other data show little, if any, change in real relative risk, but huge changes in coding. Primary care doctors are the most immediate path to higher scores, so plans incentivize them in 3 ways. They pay them more for more codes. They use value-based care, where they shift risk onto the primary care doctor, so they then have the incentive to upcode patients. And they purchase primary care practices so they can directly pressure them through their employer to gain risk scores. Example is Clover Health, a Medicare Advantage PPO in multiple states. They provide doctors with their Clover Assistant technology for free to help them code better. This is their marketing. And in the notes is, well, I'll just leave this as this is involving various incentives to get providers to code higher. Payment is based on the completion of a Clover Assistant visit, guaranteeing it not at risk. And this is where they look for extra codes. For example, they encourage PCPs to order carotid ultrasounds on Medicare Advantage patients with no symptoms, hoping to find something, and then they can add more diagnosis codes. Patient gets stroke prevention, vascular surgeons in hospital can bill for more services. Medicare Advantage plan gets higher codes from CMS. The market is aligned with the public health, right? So this is against guideline recommendations for carotid artery ultrasounds. They're not supposed to be a screening tool for asymptomatic patients, but if they find any evidence of plaque, they submit the diagnosis code, and they get $2,800 per year more per person for the rest of that patient's life in that Medicare Advantage plan. Type 2, share risk score payment. So if with Humana, physicians in value-based payment agreements can earn 2.5 times more on average than using Medicare's straight fee-for-service fee schedule. And those physicians in the most advanced stage of Humana's value-based primary care continuum, global value, earn an average of 4.5 times more than with Medicare's fee schedule. That's instead of $44 per member per month, they get $198 per member per month. Or buy PCPs and internalize the value. And this is Humana's organization for buying primary care practices. Traditional Medicare, up until now, privatization has been focused on Medicare Advantage, but there's more patients in traditional Medicare than in Medicare Advantage. So this is, the green is a much bigger opportunity for Wall Street to profit off of publicly funded healthcare than Medicare Advantage is now. And DCEs are the way to get that population. CMMI is a Center for Medicare and Medicaid Innovation, and they are allowed by the Affordable Care Act to make changes in the way doctors are paid without going through Congress, so they can unilaterally impose things like DCEs without having to have a bill passed. If HHS claims that will reduce spending without decreasing quality or improve quality without increasing spending, and does not deny or limit coverage or provision of benefits, then they can do it. The problem is they can be offered something like DCEs that claim that they will do these things, but in practice they do the opposite. But the fact that they claim they will do these things enables CMMI to implement them. So now we have conversion of this situation to this situation where their only options are Medicare Advantage or direct contracting entities. Medicare is then fully privatized. Everyone has a fiscal intermediate playing the same games, and nobody has regular Medicare. And if we're trying to get to single payer, we have a much bigger obstacle to overcome than we do right now, where at least the majority of Medicare is still straight fee-for-service, single payer. So these are the flavors of direct contracting entities: global professional capitation at a variety of risk levels, very similar to managed care, and not previously allowed in traditional Medicare. High needs, people with high health care costs who are depleting their assets or currently or soon to be dual eligible. And GEO, where you have required enrollment in a DCE in certain geographic areas, which has been paused due to concerns by stakeholders. So the sponsors of DCEs, providers, ACOs, independent practice associations, insurers, and some new entities. But of these, only 6 are insurers, but those have the lion's share of the population. So there's states with no DCE in the state, states with non-insurer DCEs, and the states with insurance company DCEs, and the number of covered lives is highest in the insurer ones. So this puts Medicare's entire book of business into play for the for-profit sector and investors. So we could go from 600 billion to more than double that in a few years if we allow this to progress. This is their marketing. They claim that with Medicare Advantage, their projections will go like this, but with direct contracting, it goes like this. And there are a bunch more besides Clover. So direct contracting entities is a prime example of a blue ocean strategy, which means you find an area that has not yet been exploited, where you're not competing with a bunch of other people, and you be the first one in there, and the ocean is blue because there's no competition, whereas if there's a bunch of competitors, it would be red with blood. This is what DCE is going after. Who can stop this? Your US representatives and senators: Xavier Becerra, HHS Secretary; Chiquita Brooks-LaSure, CMS Administrator; Elizabeth Fowler, Director of CMMI; and your Congress people. They're the only ones who can stop this train. And that's it. PNHP contact info. Okay, I'd like to open it up for questions.
Barbara,
So Steve, how do we get out and educate the public? I mean, as the media isn't going to do this, the only ones that are going to do this is the healthcare movement. And we have not been doing that very well. We seem to stick within our own. So how can we get this out? where I am in New York, my representative is a big Trump supporter. All he's interested in is himself, really, and he's gotten into trouble with sexual charges. So going beyond the politicians is how I see we've got to go to the grassroots. So I'm curious to know how this can be done.
Well, that's a really good question. And one of the things about DCEs is it's so complicated and so wonky that it's very hard to explain to people. So it's deliberately that way. It's designed to be able to sneak something in without the public knowing it. And they made it complex to make it hard for people to understand. And I think that it's very hard to know an effective way to do that. I think one thing that we can do as healthcare single payer activists is try to break it down into simple messages that people can understand. Help write op-eds, help talk to reporters to get them to be able to simplify it. Because if you just leave it up to the public, they're not going to be able to. Somebody's got to work on translating the message and getting it out.
But the nurses, there's an animation that United Nurses did about deadly shame, about their conditions of work during COVID, and using visuals with words. And of course, in this case, yes, simplifying the words, but visuals and graphs, something that people can see and take inside, and using color might also be a way of doing that.
Well, that's where Ed Weisbart's slides are very useful, because he's good at this sort of thing. And that's a pretty powerful slide set, in my opinion.
Thanks, Steve.
Others. I think Lynn was next.
Yeah, Patty, I see Patty, Lynn, and then Ronnie.
Patty and Bob Short and Ronnie Short, yeah. Okay, Lynn?
Okay, you have just explained this big mailer that I got. You just said that Essence is one of the DCEs.
Yeah.
I got this huge pamphlet in the mail. They're out of Maryland Heights, Maryland. Here you go. So here's one of the DCEs.
This is their advertising?
Yeah. And if they send it out to me, maybe it's, oh, okay. I just opened it up and I figured out my friend Cybele, Stanford Medicine a couple of years ago offered its own Medicare Advantage program, and she and her husband are in it. And she got information in the mail, and I think this is the program, because it says, in partnership with Stanford Medicine, Essence Healthcare has been working hard to put together the best Medicare package Bay Area residents have ever seen. We're looking forward to offering you the care you deserve at the lowest possible cost. The time to switch to a better medical care plan is just around the corner. It's almost time for us to announce our full range of 2022 plans. Reach out today to be one of the first to learn about all of the exciting benefits coming your way. So there you go. My question one was, so what about the competition between the Medicare Advantage Insurance Companies and the DCEs?
They're the same people, unfortunately, and the people running Medicare Advantage plans are also putting out DCEs because they want to get it all, but it's the same people.
No kidding. What, and can you explain, and it was in one of the slides, that value-based care?
Value-based payment was created with the Affordable Care Act. And what it is it's claiming to pay for value, not volume of care. And it means getting off of fee for service and switching to capitated payment is basically what it means. And putting insurance risk onto the providers of care, saying if we do this, then it will rein in unnecessary care, doctors will only deliver care that has value, and they won't do anything unnecessary because they're not being paid with fee for service anymore. And they leave out all the problems, the cherry picking, the lemon dropping, the gaming diagnosis codes to beat risk adjustment, all of that stuff they leave out.
I loved Ira Denver's comment, United Suckers of America.
Yeah.
Thank you.
Okay, who is next? Patty? Unmute.
Yes. Thank you so much for repeating Ed Weisbart's slides. I watched his presentation and it went by pretty fast, and there's a lot to absorb there. So it's really useful to see them again. And I'm wondering if you have any information about the hold that's put on the DCE GEO plan. Do you know how long that's for and when it might end, and how much time we have to react to that?
No, we don't know. We don't know if it's basically going to be dead or if it's going to be revived at some point. We really don't know. But the concerns raised where this forces people into something that they did not ask for or don't want. Do you really want to do that to seniors? Is this a politically smart thing to do? And why are we inviting Wall Street in to take over regular Medicare? They're not going to have patients' best interests at heart, et cetera, et cetera. So those are the concerns that got them to put it on hold. But whether that'll be enough to kill it or not, we don't know.
It depends on who speaks
Yes.
for it. Yeah. Okay. Thank you so much, Steve.
Okay, Ronnie?
So Dr. Kemble, can you talk a little bit more about, is there a plan for global budgeting? Is there anything happening in any legislation around that? And I think part of the problem is that you mentioned global budgeting does have to involve some reevaluation at the end of the year for a clinic or hospital that has more patients with an expensive disease, such as kidney failure or certain cancers.
Right. The global budgeting is in Jayapal's HR 1976. So that's the bill in the House that includes global budgeting. Bernie Sanders' single payer bill does not include global budgeting of hospitals. And we've been trying to persuade his staff to get him to change that, but he's also got a whole bunch of other people talking in his other ear. So I don't know whether we'll win that or not. But part of the problem is I think that a lot of people just do not understand the implications. But Jayapal is the model bill. It's built on the PNHP proposal, which also has global budgeting of hospitals. And there are a number of state level single payer proposals that do and a number that don't. Like the New York Health Act allows risk-bearing intermediaries, HMOs and ACOs. And in California, the HR 1400 does not allow them, and their other single payer bill does allow them. And so it varies from state to state. But Jayapal's HR 1976 is the gold standard. Marcia.
Yeah, thank you. So in the past, hi, Steve. It's really good to hear you again, and everyone else in the audience, see you again. In past presentations, you've mentioned how risk is such an important concept, and we should beware the idea of risk. And so in my head, I'm thinking, well, anytime you're talking about risk in healthcare, that's a bad thing. Is that true?
Well, I mean, there's always risk in healthcare, but the idea is you manage it by risk pooling alone, which means you have a single risk pool and you spread it across the whole population, and you don't play games with sub-risk pools competing against each other. That's what it means in healthcare. So you want the government to have the risk, because the bigger the risk pool, the easier it is to deal with the ups and downs because they're diluted out with a large population. If you are a risk-bearing entity responsible for 30 people and one of them gets cancer, you are dead financially. But if you get cancer and you're one of 2 billion people, it's not a big deal. So let government handle the risk and otherwise get risk out of the payment system.
So another point on that is that risks, assuming risk is a risky proposition, it has a bad sound to it. And so I think politicians, I've heard them be skeptical of having the government, the body they're responsible for legislating through, be responsible for risk. They'd rather leave it to some other outside entity. So that therefore that's why the insurance companies have such strong sway. Is that accurate?
It is. And what happens is that when Hawaii State Medicaid was a direct payment fee-for-service system, they had a problem because they would set a budget at the beginning of the year, and then they would pay the claims as they came in. And about 11 months into the year, they would run out of money. So they would stop paying doctors and hospitals for a month, and they would pass a new budget that included catching up from the previous year and an estimate for what the subsequent year would be. And then everyone would get paid and it would go along, and then 11 months in a year, they'd run out of money again. So they had this sort of a mini crisis every year where everyone stopped getting paid for a month and then catch up later. And they didn't like the unpredictability. So they were very happy to turn it over to managed care companies who said, you give us an agreed upon amount at the beginning of the year and we'll cover it for you. You don't have to worry about it. The problem is, once you do that, the managed care companies have the state over a barrel, and they can force any increase in premiums they want through, and they make sure that they get enough so they're very unlikely to lose money. And so the state pays a premium to give somebody else the responsibility to pay that risk. And this is true every time you transfer risk. The best way to make money in almost any industry is to take on risks, because you can always milk the source of the money for more than you're likely to lose in order to take that responsibility of taking on the risk. So you always, as a payer, you always lose by contracting the risk to someone else. I had a good friend who was an architect and project manager, and he said he strives in every way he can to eliminate risk from a construction project by planning things out in detail, trying to think of everything, trying to have everything as cut and dry as possible, because anytime you leave it vague that there's some risk involved, that you haven't nailed down the details, you're going to have to pay extra for it. And the only way you're going to come in on time and under budget is to get rid of as much risk as possible. Same thing applies to healthcare. Risk is your enemy, unless you strictly spread it across the entire population.
I think it's Maureen and then Lynn again.
Hi, everybody. Hi, Steve. It's so great to hear you again. I always love your explanations. You're so clear. I have a couple of questions. The first one is actually, are integrated delivery systems different in any significant way from an HMO and an ACO? That's my first question. And my second question is that companies like Aetna is now offering a zero premium payment option that it says is available to 84% of Medicare eligible beneficiaries. And that was announced October 1st, I think. So I'm wondering, one person explained that as, well, yes, because they made so much money not giving people care during COVID that they have to meet that 80%, 20% metric in the ACA. But I'm wondering if there was any other reason, because I know prior to this, people have been paying like $1. You know, I mean, they're drawn in by these things that I'm wondering, I mean, are they making so much money that they can actually offer that kind of a premium? So the two questions, the IDS question, and then the question about how can they offer these zero premiums and dollar premiums? Do you know?
With the first one, an integrated delivery system, this is what we've been discussing in the policy work group. An integrated delivery system is not very clearly defined. Does this mean doctors, and a hospital all working together in a coordinated way to enhance patient care? Or does it mean fiscal integration where all these people get together, get paid capitation, and have an opportunity to profit off it? And it's always sold as if it's the first, but it usually turns out to actually be the second. The solution to Kaiser in Jayapal's HR 1976 is that a multi-specialty physician group in a single hospital can agree to join together to be paid under a single global operating budget that includes the hospital's operation costs and the salaries for the doctors. And so then they are an integrated care delivery system, but they're not paid capitation. They're paid a budget and they can't retain earnings. And if they lose, they can ask for a supplemental appropriation, but they're not taking risk. But they are integrated because they're under one budget and they share one electronic health record. That's okay. What you don't want to do is to allow them to say, you give us a set amount of money and we'll take the risk and we'll make sure we charge you enough so we're not going to lose money. That's what you don't want. They don't say the last, but that's implicit.
A
That's
quick clarification about that is, does that mean an integrated delivery system has to have a network? So you have to be in a network?
It has to not have a network to be a pure integrated delivery system without insurance risk. Once it has a network and it's paid capitation, it's bearing insurance risk. So if you want the integration without paying for the risk, what you do is you globally budget the hospital and doctors together, and you don't fund insurance functions, and you don't expect them to bear risk. You say, we'll give you a budget, you do what you need to do, you got the money for the salaries, you got the money to run the hospital. If we misjudge it in some way, we'll renegotiate it in a year or whatever. Whereas what integrated delivery systems are almost always angling for is they want to be risk-bearing entities. They want that opportunity for profit. They want to be able to game the diagnosis codes. They want to be tapping into that money machine that Ed Weisbard talked about. So they call themselves integrated delivery systems, but they're really looking at financial integration and the opportunity for profit. It's really only Jayapal's bill that spells out, and the state bills that do the same thing, that spells out what we mean by an integrated delivery system is just a delivery system, no insurance functions, no corporate chain management, just the delivery system. The doctors and hospitals working together. We'll fund that, period.
Thank you. And then my second question was about how these insurance companies can offer zero premiums and say that 84% of Medicare recipients are eligible for this.
That's easy because the 16% they don't cover are almost surely the sickest people.
Okay. So
if they can capture a healthier than average risk pool, they can look like they're saving money because they're spending less per person. And they say we're meeting all these quality metrics. Let's say they only set up their clinic in wealthy suburban neighborhoods where everybody can afford their copays and they generally are compliant with care and they don't have a lot of social problems. You don't need to work as hard to take care of those people. They do a better job of taking care of themselves. They can afford to fill their prescriptions. So your quality metrics look great. Your cost per person is less, but it's a shell game because they've captured the healthy people, pushed the sick out. They're still in regular Medicare or somebody else's plan where their costs are just as high as they ever were. The whole system is getting milked for money while the plan makes themselves look good.
And other quick question, I'm sorry, then I'll relent. But it's my understanding also that with these Aetna can offer that this year, but Medicare Advantage plans can completely change the contract every year. Is that correct?
Yeah,
and
well,
whereas original Medicare cannot.
Yes, and Medicare Advantage also can make it very difficult to leave Medicare Advantage because if somebody has been in Medicare with a supplement, that covers whatever Medicare doesn't cover, and they go to Medicare Advantage, and you want to go back to Medicare plus a supplement, the supplement can do underwriting and deny you coverage based on your pre-existing conditions. So you're kind of trapped in Medicare Advantage unless the Medicare Advantage plan doesn't want you, in which case they find ways to disenroll you or they make it so unpleasant to be in their plan because you can't get the drugs you need to cover your expensive condition that you're forced to leave, even though you can no longer buy a supplement plan.
Well, and the scary part to me is that with all the upcoding that the Medicare Advantage programs do, is even if you're really healthy, if you try to get a supplemental, because I'm in that now, I'm leaving a Medicare Advantage and I want to go to original Medicare. I haven't researched it yet, but it's my fear that, I mean, I'm healthy, I take no medications, I'm 71. But when I look at my healthcare record, I don't recognize myself, okay? Because they have put everything under the sun there. And every time you go in, they offer you some medication, some prescriptions I never take. And so I'm worried that if I go to get a supplement, they'll look at the record and say, oh, she has these things, but I really don't. I mean,
That's
so
a
it's
real
kind of
risk.
scary that that's the way they trap you, is with the upcoding. I mean, it's more than just making money. They also can trap you.
That's true. And I think that point is one of our best selling points to explain this to the public, because that really gets people going when they're told your plan is giving you all these diagnoses that you don't really have so they can make more money off you. And those diagnoses are going to follow you if you try to leave the plan. Did you know that? That gets people upset, and we should be using that.
May I jump in? That made me have a question. Oh, darn. So, oh, I'm sorry. I need to, I'll think of it again.
Can I say something?
Yes.
Is it true? I've heard this, but I don't know if it's true. Kaiser, when you turn 65 and you're in Kaiser, you are automatically in a Medicare Advantage and you cannot have anything else if you want to stay in Kaiser. Is that correct? Do you
I
know?
think that's correct. Kaiser Medicare is a Medicare Advantage plan. That's how they've organized. That's how they take care of their Medicare beneficiaries. The difference with Kaiser is that you still have the full Kaiser network. Whereas if you're outside of Kaiser and you switch from regular Medicare to Medicare Advantage, suddenly you have a much smaller network that you're dealing with. Whereas with Kaiser, it stays the same. So it doesn't matter as much with Kaiser as it does outside of Kaiser.
May I jump in?
Yeah.
As I understand it, the zero premium, like someone said, is a teaser. And where they get their money are the co-pays. And I'm working with an insurance agent who got me a better supplemental plan. I'm going to be saving $71 a month. So everyone should get hold of one of these SHIP counselors to help you. But she gets every fall, open enrollment, October 15th to December 7th. She gets inundated with Medicare Advantage patients who find out that it's not as great a deal as they were led to believe.
Right.
And isn't it true, Stephen, that they can deny treatments and tests and all that kind of thing?
Yes, Medicare Advantage, unlike regular Medicare, Medicare Advantage can have narrow networks, prior authorizations, restricted formularies, all the things that managed care plan, all the games managed care companies play are open to Medicare Advantage plans that are not applicable in regular Medicare. So, and of course, this is never in their ads.
The other thing is, I just looked at the brochure again of this Essence company. And this is being advertised in Alameda, San Mateo, and Santa Clara County residents. So it sounds like Stanford and Essence are going to kind of control this geographic area. So this sounds like a geo.
If it becomes complete where everyone is forced into one of those plans, it would be like a geo, but the geo program has not been implemented. So I don't think it actually is, but it's trying to get as close to it as they can. I don't know how we can fight the insurance company marketing because it's happening rapidly all around us. I think our only hope is to appeal to politicians to stop it at the Washington level.
Yeah, but Stephen, the politicians take money from the insurance companies, even in New York State, in the New York Health, well, is it New York? No, I shouldn't give that example, but the politicians, even who support single payer, and you can go to Rendon back a ways in California, he wouldn't bring the bill from the state, the Senate to the floor because he was taking money from the insurance companies. So this is a big problem, or the pharmaceuticals. I mean, it's basically same. So
You're
this
right.
is the
You're right.
problem.
Huge problem.
And on top of that, the fact that Liz Fowler is the new
Yeah.
CMMI, I mean, that's horrifying. Liz Fowler, who's originally from Anthem, right? I mean, WellPoint. And she's, was in Baucus's healthcare committee. It's just that famous, wonderful clip of all the physicians being dragged out in handcuffs, at the hearing. Margaret Flowers was there and Carol Paris and so many others. That Baucus was praising Liz Fowler, and then Liz Fowler helped implement Affordable Care Act with under Obama. Then she went to the Commonwealth, which was kind of scary that she got there, and now she's back as the CMM Innovations chief administrator. That's like, and the fact that they don't have to ask. The CMMI doesn't have to ask Congress to approve.
Yeah.
That's what I read, is that they don't have to
That's
ask
correct.
Congress to
Yeah,
approve.
that's correct.
And that's really scary.
She wrote the bill. She wrote the ACA with Baucus. They sat together, and Baucus he had insurance camp where he'd invite all the insurance execs to come out to Montana. I mean, and the biggest problem is the money. Matt, this is what the problem is with this system, why it is so difficult. Plus the media not educating people, they never talk about this, but the money and the length of elections in this system is beyond the pale. So this is very, very difficult for us.
Sherry, you still have your hand up? Sherry Lambert?
Yeah, I had my hand up, and I was just going to say, you've answered a lot of the questions I've had, but I think we need to tell people think that physicians are getting rich. They're actually not. It's the entities, it's the investment companies, it's all those people. But the average person, if they don't follow this, doesn't realize where the money is going and who really is getting rich. But even, rural hospitals are going under because of, the lack of funding going there now. But we have to, I'm worried that this is just going to take, it's already taken so long to get a single payer system. And I'm worried it's going to take longer. I want to find out the most efficient way we can, besides talking to Congress, just writing letters and trying to get out in the public and talk about this.
So we took the privilege of embarrassing Representative Kurt Schrader. He was the one to vote against the drug negotiation process here last week or so. So he's had a demonstration in front of his office in Oregon City, and he's felt it necessary to set out a newsletter not apologizing, but defending his action and saying that he has a substitute bill. So that's one route, is embarrassing the legislators.
Good, thank you. And the other thing is, I get really frustrated this time of year because we can change our insurance. And we get every day, we get pamphlets from Humana and Aetna, and it's a waste of money, it's a waste of trees, and it's a money earner for them.
I think Maureen had her hand up again, and Lynn.
Yes, it was based on what I'm sorry, I forgot your name, but the woman who just spoke, and that's another issue about Medicare Advantage. Doctors should be really concerned because everyone will be an employee. And once you're an employee, you are completely and totally under the thumb of your employer. So for the first time ever, 51% of physicians are now employees. And the more Medicare Advantage patients we have, the more doctors are going to be forced into being employees.
That's already happening rapidly, but if we're all employees, we can unionize.
Yeah, we hope you do, like CNA. The other thing that was interesting to me, Becker's hospital reports said in the first 4 months from January to April, there has been this enormous push for to expand Medicare Advantage programs. And they had United Health is adding 276 counties. Clover Health is nearly doubling its Medicare Advantage reach. Senior Market Sales is working with Walgreens stores, 350 Walgreens stores, where agents can sell health plans. Cigna, Humana, Healthcare Service Corp, which is Blue Cross and Blue Shield plans. They are all competing for Medicare Advantage enrollees by adding all these counties. So there's like really 1,000 or more counties being added to these Medicare Advantage programs. I'm wondering if that has anything to do with, I guess it doesn't have to do with the DCE because you don't have to be an Advantage to be subjected to the DCE, but it's kind of scary how fast this is all rolling out, you know?
Maureen, don't forget CVS and Aetna who merged, and what they're carrying on. It's so, this is all under the radar. And then all of a sudden we're going to be like prisoners of these companies. Steve or Mike, how much debt do doctors from going to medical school, how much debt do they continue to maintain throughout a good part of their career? So here, going back to the point where people saying doctors are rich, how much debt are they, maintaining that have incurred?
I think it's typically 250 to 400,000 when they come out of training. And what happens is that they are deterred from going into any lower paying specialty like primary care. And they're incentivized to go into some more lucrative subspecialty. So you get more surgical subspecialties and cardiologists and things like that, and gastroenterologists, and a lot fewer primary care doctors, because otherwise you can't pay off your debts. And the fact of the matter is, the subspecialists are actually doing well in this country, but the primary care doctors are not. No. They're not. They're barely making it, or they're not making it, or they're forced to out of practice and into employment. And another thing is when a primary care doctor or a specialist, either one, is in private practice billing fee for service, they make, let's say, X amount of money. If they're hired by the hospital can charge 1.75% of X or 225% of X, because they get to add on a facility fee, and they have the size and the clout to force higher fees out of the insurance companies. So forcing doctors into employment raises costs for everyone.
And of course, we all have such a primary care shortage in this country. It's terribly short. And pediatrics, I would assume, is also not good.
Yes.
And we're the only, look, student debt is so horrendous in this country. We're like the only country that does this to people. So, and medical debt, it's beyond the pale. Anyway.
Lynn?
Hi, when I looked up the 3 Democrats who voted no, Schrader, Rice, and Peters, I found an article that talks about, like you said, the bill. They have written a bill that talks about drug companies, and they even talked about America. It's a very, I should send that article out, but it's very, very strange. A piece of legislation that they're doing for themselves instead of, supporting that Medicare expansion part. But I think, as I understand it, the good news is the Ways and Means Committee supports the drop by, negotiation with Medicare. And then I just saw Rachel, who's Madley, who's working for Jayapal, was on a program the other night, and it's still all up in the air what is going to eventually go into the Medicare expansion. They think that the lowering the age is not going to fly. The dental, and of course those benefits, they still are saying won't come true until the 2028. And so there's just a whole bunch of, but the progressives are hanging in there. If we don't get some of that stuff, they're not going to vote on the infrastructure.
Yeah.
So it looks like this plan, this Liz Fowler is basically like she did with Baucus and refusing to allow single payer at the table. This is a huge movement against single payer.
Marcia's got her hand up.
Right. I was remembering something that I heard, a couple of tidbits of maybe gossip, and maybe it's true and maybe it isn't, but that there's a link between Kristen Sinema and the drug pharmaceutical companies, that she's lining up a job for when she's out of office, that she would become involved with a pharmaceutical company. And I can't cite the source except that it was hearsay and might not be true, but I think if that's, it'd be worth following that, to publicize that to our single payer supporters and just to the general public. And also, I remember there's a daughter of somebody, one senator, it might be Senator Manchin, who's works for a pharmaceutical company. And those links, the family ties, the personal gain that politicians are getting or will get from the pharmaceutical companies would be a good messaging and rallying cry, I think, for our people that like we are outraged by the prices.
Kurt Schrader's father or grandfather bequeathed a large Pfizer inheritance to him, and he gets large amounts of contributions from the pharmaceutical industry. So people are pointing that out in letters to the editor, and I challenge everybody on this call tonight to create a letter to the editor explaining what Medicare Advantage does and doesn't do. It has to be written carefully to not appear to be critical of Medicare itself, but people need to know what's going on.
Thank you.
Marcia, you're absolutely right. I put the information about Manchin's daughter in the
Oh,
chat.
thank you. Thank you. You know, can I ask a question that's not about insurance companies, but it's about hospital billing? Now, maybe there are enough bright minds on this call to give me an answer. I wanted to know the answer to this question ever since I became involved in 10 years ago with single payer actions. So I had a recent procedure, and the insurance explanation of benefits shows the bottom line charges from the providers at $32,045. Yet the cost that the plan approved, my insurance plan is a Regions Med Advantage, was only $2,689. And that's considered, and the plan's share, of course, was $22.89, and I paid $400. So I got a real deal. But I'm wondering, how can hospitals, what can hospitals live with? And what does that contract look like that Regions wrote with this hospital, where they can write off that much of the cost of the procedure? Almost $30,000 has just disappeared. Does anyone know how contracting works like that?
Yes, the best source, I'm just going to jump in. The best source is David Belk, who's a physician in Alameda, California.
Yeah.
And it's called True Cost of Healthcare. His book is fantastic, and it's a lot of charts. It is so clear to see. He has a lot of things on his website, and basically, very simply, the price of something is not the cost of something. The price is what you pay.
Yeah.
But that it often has, what he says is that hospital bills, for instance, are works of fiction. That's his most famous mantra. Hospital bills are works of fiction. And his book is, I think it's called The Great US Healthcare Scam.
Yeah.
It really is a good book. I highly recommend it. And just go to his website, truecostofhealthcare.org. Invite him to come and speak to your groups, your chapters, whatever. He's a wonderful speaker. He's like Steve in that he's just like right on, nitty gritty, talks it like it is in a very conversational manner, which makes it easy to understand and makes it fun to listen to. So anyway, you know, I highly recommend that. truecostofhealthcare.org. David Belk, he and his brother have been researching hospital billing systems for, I think, 12 years, maybe 15. I mean, I had him come speak like 10 years ago, so, and recently, but highly recommend it.
Yeah, excellent book. I recommend it too.
Yeah, thank you for reminding me of that, Maureen. That's really excellent. So it sounds like we can maybe have a campaign of guess what my insurer says the hospital charged, and and here's what they pay, well, what the true cost must have been then. And we can maybe just, I don't know,
Yeah, I have
share
to
your
say,
bills, share your EOBs.
I have to say for my mom, it's very interesting. Kaiser is always like $1,000 an hour. If you're hospitalized, my mom was hospitalized for 32 hours, it was $32,000. When she went to physical therapy, 15 minutes was $250. When she went for some other procedure, I mean, this is what they charge Medicare, not her, but it was I looked at all these bills from different kinds of treatments and the hospital, and it always worked out to $1,000 an hour. So I'm thinking they have a very lazy actuary who just figures out, how do we make this $1,000 an hour? Because everything, I'm serious, everything worked out to be $1,000 an hour. So
The other problem that I see just in general with Medicare for All is the US is such what I call phony individualism in the Sesame Street mentality. So if I have it's good, I'm not going to worry about anybody else. So this is a problem in terms of getting people unstuck in their thinking, and also the fears that they have of the unknown. And not that it's the unknown, every other normal country in the world has a single payer of some sort type of system. And how to get past all the, past all this, because we're running into walls, into getting tight for time, And I talk to people all the time in the street, and so many people still do not have any idea what single payer is. And I know we're talking about Medicare Advantage, or as I say, disadvantage, but there's got to be a way that we can get out to the populace, and especially marginalized groups. And I am a big rural area. I think that's very critical. We need to be doing this, and yes, we're up against big money, but there's got to be a way to do this. And of course, Americans, if you watch television, the grammar is 4th grade. That's the sentence structure, is 4th grade sentence structure. Media literacy, by the way, is a topic. Ithaca College has the Look Sharp program, which helps people to analyze, teaches people how to analyze audio, print, and visual media, television, and so on. So I don't know, maybe this could be something we could use so that people understand that how they're being messaged, and that it's all not really, it's not true. Yes, and as you're saying, yes, and NPR too, we have to throw them into the mix, their own. Go ahead.
Marcia, your hand is up, and then your hand is up.
No, sorry, I didn't take it down. Let me take it down.
To mention that One Payer States has a communications work group that is actively working on just the things you've been talking about, Barbara, and firing up a social media presence, thinking about short videos and producing them. AJ Marwala has produced about 8 of them that would be appropriate for Instagram or Facebook. So I encourage your groups to do the same thing, and come to the communications work group meetings. I'll send that out when I send the schedule for that, when I send out the recording from this meeting tonight.
But Mike, the other thing that we are neglecting, and we seem to become complacent, is that not everybody has broadband or can afford it. And as I was talking to Chuck, and this is for a later conversation, but we've got to be able to have ways, hard copy, and ways to be able to sit, and I have a storytelling workshop to sit with people in the flesh, as I say, and develop relationships. That's what is the most important thing. If we're going to make change, then they can go and to their congresspeople and say, listen, you don't, do for us, you're out of here, and then again, of course, as we've seen in New York State, where the bill, and most of that was the unions, where the bill would come to the, was in committee and Stuart Cousins pulled the bill. A lot of these people turn tail and run, so this is, it's like, we've got to get the people on our side and well-educated. We have opportunity. This is a new system. Anyway, I'm done.
So we have a recently retired health economist listening. Keith, you have comments from what you've heard tonight?
Yeah, I have many. I'm curious about the direct contracting effort of trying to further privatize Medicare. Once you start privatizing, the one good aspect is if they are publicly traded, they're going to be also subject to various federal securities laws. And I'm curious if that is the case, where is the money coming from for these entities that will be controlling Medicare if it is totally privatized? I'm also curious, as we know, Social Security benefits are used to pay Medicare. So breaking that system apart is not going to be the easiest thing in the world to do. I share everyone's thoughts about how do we get the message out, and one way is, as we know, keep it simple. A media message would be direct contracting is privatization of Medicare, period, end of discussion. All you have to do is say the word privatized to most of, I'm looking at this audience, we're all in the same age group. You say privatized and our dander is raised, and we get very, very active. It also is a sensitive word for others who are looking at hospitalization. I know a lot of doctors who are fed up with the current overall healthcare system. My daughter's a doctor. Her clinic, most of the doctors she practiced with are saying there's got to be a better way. So doctors are a strong group that we need to tie into and get the message out into the media. So there are multiple parts of this that again have piqued my interest, and they're the two I just summarized. As a lawyer, I always look at ways of stopping momentum. You can either do it through the media or you can sue them. And I'm curious about developing, some of the nonprofits I work with. I've given up on the ACLU. They're not a big friend. But again, lawsuits get everyone's attention, as we can see in the media right now. So I would be curious as to figuring out ways of stopping the direct contracting by filing some lawsuits, because again, a lawsuit gets media attention. So again, many thoughts are buzzing around in my head right now.
You ask where the money comes from. The money, over half of it is actually funded by insurance companies. There are also ACOs, which are formed with hospitals and groups of doctors. And there's usually insurance company backing for them too. So that's where some of the money comes from. And there's private equity investors who are interested in this and want to get involved in financing the organization of DCEs so that they can profit off them.
The private equity route is something that has been the last 20 years needs close watching because they're not regulated. They don't fall under the financial regulatory scheme, and they are a huge source of money. Again, their hesitancy again is private equity companies don't want to get involved in a venture that is going to subject them to any kind of overseeing. But yeah, we all know that the insurance companies are the main villain here. That's where all the money is coming from. So again, there's a couple different avenues to stop this train from continuing down the track.
Keith, who would you see as suing, as doing an action against these companies? What kind of people would have the
Well,
capital?
My first interest always is if they're publicly traded, I'll go out and buy one share of stock, and now I've got an interest. I want full disclosure. And if they're using their funds to invest in this area, again, it has to be part of their annual report. So again, that's where you start filing full disclosure suits against them as a shareholder, and you'll get their attention and the media's attention real fast. So again, that's why I was curious when Stephen mentioned, again, if any of the money is coming from public entities, they're subject to other federal laws that can be used to go after them and stop them, or again, get what they're doing out there in the media. It's a media strategy.
Public citizen would be a logical source of a lawsuit as well.
Caroline?
Yeah, I was gonna follow up briefly, I hope, on Keith's comment about the lawsuits. The one that jumps out at me that I'd always wondered about with these closed networks of health insurance is especially on the pharmacies, just because that's a little plainer and clearer. If they narrowly bind you into getting your drugs at one or two pharmacies, it's very anti-competitive. You can't even go somewhere that would sell you the drug for less. And unless there's a specific carve out in some kind of healthcare legislation, and there may be, I'm surprised there hasn't been some kind of it wouldn't be vulnerable to some kind of anti-competitive lawsuit.
Well, now you're talking about the Sherman Antitrust Act, and again, that's why an in-depth or deep dive into these companies, how are they financed, in order to figure out what type of strategy would be best used. Again, I'm talking as a black sheep lawyer, that good lawsuits get good publicity, and good publicity is a way of stopping momentum.
Any other questions from people who haven't spoken up? Ira, you've been silent. Kay, Lasker, Nancy, Sumitra, Susan.
I'll say something.
No, Ruth.
I would appreciate it if those who have mentioned letters and different information such as that, if you could send it out to everyone, that would be a help for some of us.
I'll send mine out. I'm going to write one in, and I had a 600-word piece a year ago.
Oh,
And I'll just send that out as well.
okay. Thank you.
I'll just make a comment that I think, as it has always been with single payer, is that education is the key. I mean, because like someone mentioned earlier, some people don't even know what single payer is. And, we've been working on this for 30 plus years and trying to get people to understand, but it's such a complex issue. I mean, just understanding insurance, even if it worked right, would be difficult. And, trying to get people to understand. I can't even convince some friends of mine to not get Medicare Advantage. Even though I go, and these are smart people who can understand what I'm saying, and they still are reluctant. I don't know if they like the silver sneakers class so much that it's worth it. And so they stay with it. But we just have to keep, plugging along, because we have to get the information, because that's what people will we have to get people to understand and respond to that. Talking with Congress people and other politicians is important. I just worry now that after Citizens United, I don't know if there's a difference between Congress and corporate America anymore. And what, I don't know how much talking to them, will work, because I've been surprised by some people who I always thought were on the right side of the fence, who have said some things and remarks that I found rather shocking. So we have our work cut out for us. There's no question about that.
Can I propose an idea I have? This is Kay. We're trying to get people interested in the details, so that we have to offer them something that'll concentrate their ideas. A few years back, there was a very big interest in these big quiz things. Who's going to win the quiz? And they would ask some basic questions. Or they also did some other on TV where they simply said, score yourself and see how, and they did it with a big bang. And they set up a series of questions, and people scored themselves as to how they answered it. And then they made a big deal of how good a score you got. And this would be all on Medicare and how people understand Medicare. And then there have been some other programs where they actually offered a prize to the people who got, high scores. So something along that, people who aren't normally interested in issues, but are interested in money, they all go out for the lottery. Everybody goes out for a lottery. So it's a form of a lottery, but it's in the form of a big quiz. And that can be done regionally or very locally in a community. But you'd have to be careful about the questions you created, and then create and offer a prize. And people will come for a prize. So that's an idea I've had in my head for a while.
I think it's Ira and Sherry and Barbara again.
Yeah, thank you. Let's see. In the chat, I'm sorry, who was it who's the attorney?
Oh, Keith.
Sorry?
That's Keith.
Keith, thank you. That was really interesting. And you got my mind kind of cogitating on, what kind of legal solutions might there be? And so, as I posted in the chat, I'm wondering if mathematically there's any way to show that this gold rush, Wall Street's gold rush, to enroll and upcode people is not sustainable. That essentially it operates like a pyramid scheme, where eventually you run out of stuff, and the growth comes to a halt. At which point stock prices crash, because the stock price increases are based on explosive growth. Therefore, I'm wondering if the whole scam can be framed as a form of stock fraud.
Okay, we'll ponder that one. We're within 3 minutes of completing, and we'd like Steve to sort of give us final marching orders. But Sherry and Barbara are up.
Okay, I just wanted to say, I think for the general public, we need to use the KISS theory, keep it simple, stupid, and just tell them the financial advantages to them. And what hasn't been explained, I don't think enough, is where the money is going to come from for this. We know it's taxing the wealthy and all these bills, but that's people's first question. How are we going to pay for it? And you can't convince them that their taxes really aren't going to go up if they're earning less than what, 400,000? But it's the corporations and the big boys that are going to have to foot the bill for this. So I think if we can get that message through to them too, it's the equity firms that are taking the money, and the insurance, the companies are feeding that, and just get the truth out there in simple terms for them.
Well, the whole money machine of Medicare Advantage and also Medicaid managed care is designed to suck money out of publicly funded health insurance, Medicare and Medicaid. So they're going after taxpayer dollars. And once they have their teeth into the system, they can then demand more with impunity because the state has relinquished control, or the government has relinquished control, giving it over to them, and they can charge whatever they want and force it out of the taxpayer. So we all end up paying for this.
Yeah,
There's a wonderful graph, and I wish I could remember who it came from. Might have been Kaiser. It shows the, I think it's the OCED office. Yeah, I think it's the OCED graph, and it shows how Europeans pay on the average $4,000 per capita, and that's all taxes. And then some pay a little bit more, like maybe would be not more than 5,000 in total out of pocket, some of the systems, but it's basically not more than 5,000 per capita, typically 4,000. Then it shows the United States. It says $7,000 per capita in taxes and $4,000 per capita out of pocket, which makes it $11,000 per capita in the United States. So the graph is wonderful. You see 4,000 in Europe, period, and then 7,000 in taxes in the United States, and then another 4,000 out of pocket. I mean, it's really a stark and very powerful graphic. I think it's
Don't forget the Defense Department, how much money the Defense Department takes from us. And this is why our programs, we are just going down the tubes. We've written a check for our own demise. I just wanted to say, based on what Dr. Rogers had said, maybe and I feel that we need to look at healthcare not as a political issue, but more as a moral issue, that we need to change our approach to bring more people into the conversation. Because by using political, we are feeding into the divisiveness that's evident in this country. So I'm thinking we need a different way to do things, more along what Reverend Barber, says, how he operates, and in terms of bringing history into the conversation so that we have a point of reference. And this is where we've ended up. I mean, there have been attempts throughout the 20th century to bring about a single payer system, from Theodore Roosevelt, Truman, even FDR. And the capitalism is just killing us, so.
I think that Steve may have an appointment down near the shore here pretty soon. Steve, you want to summarize things for us? Tell us what we should be doing.
Well, I do think that we have our work cut out for us, and there aren't any clear pathways out of this, because the other side is moving fast, which is really scary how rapidly it's happening. But I think that we need a moral argument, we need a fiscal argument, we need shame, and we need to persuade doctors, and we need to get patients scared about having their diagnoses upcoded by an insurance plan, then have it held against them for whatever else they want to do in their life, switch plans or get life insurance or whatever, all these things. And we need to just keep pushing on every front we can. I don't, and even then, this is going to be a steep climb.